a 65-year-old female presents with neck fullness and progressive exertional dyspnea. I am showing you her posteroanterior chest radiograph and an axial contrast enhanced chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates a well-defined mass in the superior mediastinum and thoracic inlet, causing marked lateral displacement and narrowing of the trachea. The axial contrast enhanced computed tomography scan confirms a large, lobulated, heterogeneous anterior-superior mediastinal mass that causes direct compression of the trachea. The mass contains multiple cystic spaces and areas of coarse calcification.
State your primary diagnosis and the anatomical compartment where this mass is located.
The primary diagnosis is a substernal thyroid goiter, and the mass is located in the anterior-superior mediastinal compartment.
If I tell you the patient also presents with mild dysphagia and a palpable neck mass that moves upwards on swallowing, how does that support your diagnosis?
Those clinical signs are classic for a goiter originating in the neck. The direct continuity with the cervical thyroid gland seen on the computed tomography scan confirms that this mediastinal mass represents a substernal extension of the thyroid goiter.
What is the most common cause of a thoracic inlet mediastinal mass in an adult versus a child?
In adults, a thyroid goiter is the most common cause of a thoracic inlet mass. In children, a lymphangioma, also known as a cystic hygroma, is the most common cause.
Which computed tomography imaging features of this mass make an untreated lymphoma highly unlikely?
The presence of multiple cystic spaces and coarse calcifications makes untreated lymphoma highly unlikely. Untreated lymphoma in the mediastinum is typically homogeneous and rarely calcifies before therapy.
Describe the computed tomography attenuation characteristics of normal thyroid tissue on non-contrast scans, and explain why they occur.
On non-contrast computed tomography, thyroid tissue displays high attenuation, typically between 70 and 80 Hounsfield units. This hyperdensity is due to the high endogenous iodide content of thyroid tissue.
Do thyroid goiters typically enhance following intravenous contrast administration, and what is the enhancement pattern?
Yes, thyroid goiters demonstrate intense, prompt, and prolonged heterogeneous contrast enhancement due to their abundant vascularity and active follicular iodine uptake.
Explain the airway safety concern associated with chronic tracheal compression by a large mediastinal goiter.
Chronic compression can cause tracheomalacia, which is the softening and degeneration of the tracheal cartilaginous rings. This increases the risk of tracheal collapse during induction of anesthesia or extubation.
Discuss the clinical precaution regarding the administration of iodinated contrast in a patient with a suspected autonomous thyroid goiter.
Administering iodinated contrast to a patient with autonomous thyroid nodules can precipitate a life-threatening thyrotoxic storm, known as the Jod-Basedow effect. Therefore, thyroid function tests should be checked before contrast injection.
How does the administration of iodinated contrast affect subsequent diagnostic or therapeutic radioactive iodine management?
The iodine load from the contrast agent saturates thyroid receptors, delaying any diagnostic radioactive iodine scans or therapeutic radioactive iodine ablation for 6 to 8 weeks. I would recommend referring the patient to endocrine surgery and checking thyroid function tests.